Good afternoon. I'd like to welcome you to this afternoon's session. My name is Shireen Olivieri, and I'll be moderating this session. Our first session this afternoon is Oncology Supportive Care, given by Dr. Leanne Norris. Dr. Norris is a clinical assistant professor at the Department of Clinical Pharmacy and Outcome Sciences at the South Carolina College of Pharmacy in Columbia, South Carolina. Dr. Norris completed her PharmD at the University of South Carolina, Columbia, South Carolina in 2004. After graduation, she completed her PGY1 at the Moses Cone Health System in Greensboro, North Carolina. She also completed her PGY2 at the Regional Cancer Center within the Moses Cone Health System as well. She currently practices at the Williams Jennings Bryan Dorn VA Hospital, where she's a clinical pharmacy specialist in medical oncology and hospice and palliative care. She was the 2010 recipient of the Hematology Oncology Pharmacy Association New Practitioner of the Year Award, and her research interests include supportive care, hospice, palliative care, and medication safety. So here is Dr. Norris.
All right, thank you for that introduction. Thank you for the ACCP staff for inviting me to speak this year. This is actually a really great meeting to come and speak at, and as probably all of you have always enjoyed the venue here in Reno if you've been here before. Hopefully you're 3 days in, so you're not completely tired of coming and learning, or maybe refreshing if you're here taking the Recertification course. So we're going to try to make this as painless as possible. This is the area of oncology and supportive care, so we're briefly going to touch over some of the important topics that you would need to know if you were, a board-certified pharmacotherapy specialist. So most of this does have to do with the supportive care, taking care of an oncology patient, not necessarily knowing every specific cancer type and or having to memorize regimens, that kind of thing. So we're going to touch and address the main issues that you would see if you were practicing, again, on how to take care of a basic oncology patient. So I have no conflicts of interest to disclose. So the learning objectives really for this chapter are to identify and assess and then recommend appropriate supportive care type management for the common complications of patients who are taking chemotherapy. And those would include nausea and vomiting, febrile neutropenia, myelosuppression, the appropriate use of growth factor therapy, both with anemia and erythropoietic stimulating agents, and then also our white colony stimulating factors such as our myeloid growth factors, what to do in terms of treatment of fatigue, and then also how to prevent cardiotoxicity and any type of extravasation injury. Also covered in this chapter briefly the management of cancer-related pain, and so we will address a couple of questions today pertaining to that. And then finally, assessing and recommending some of our therapies for the specific oncologic emergencies. So hypercalcemia malignancy, hyperuricemia, and spinal cord compression. For the purposes of today's presentation, we will not go over a specific case relating to this, but there are several cases in your course book that will provide you examples of how to treat the specific type of oncologic emergencies. Okay, so patient case number 1. We have a 60-year-old woman who was recently given a diagnosis of advanced non-small cell lung cancer. She is going to begin treatment with cisplatin 100 milligrams per meter squared plus navalbene or vinorelbine 30 milligrams per meter squared. Which one of the following is an appropriate antiemetic regimen for preventing acute emesis? So hopefully you all have your cards ready and are willing to participate. So A is the blue, aprepitant plus ondansetron plus dexamethasone. B, aprepitant plus prochlorperazine plus dexamethasone. C, aprepitant plus granisetron plus ondansetron. And D, lorazepam plus ondansetron plus metoclopramide. So if you can hold your cards up. All right. So before we can appropriately recommend management for nausea and vomiting in a patient on active chemotherapy, we do have to make sure that we understand the definitions and the different types of nausea and vomiting. So 3 basic definitions: nausea, the inclination to vomit, a feeling in the throat or the epigastric region. I think we're all familiar with this definition. Vomiting is the actual expulsion, and then we have retching, which is just the labored movement. However, more importantly, really, is to determine and to know the different types of nausea and vomiting in terms of acute, delayed, anticipatory, breakthrough, and refractory. And these are really important when going through and kind of helping manage and recommend an appropriate therapy. So acute nausea and vomiting is defined as 18 to 24 hours after a chemotherapy agent has been administered. Delayed is 18 to 24 hours after chemotherapy. Some of our more common type regimens that we really expect or see delayed nausea and vomiting would be a cisplatin-based regimen, so that's a little bit of a hint for this case. Anticipatory is a little different. This is actually a sensory type mechanism. Is triggered by sight, smell, or sounds due to inadequate control of nausea and vomiting in the past. And this is often thought to be one of those that is very difficult to treat. And to be honest with you, as practitioners, we don't always do a great job of assessing anticipatory nausea and vomiting up front. To kind of give you a quick example, it could be as simple as a patient has a specific routine that they only do every time they go and get chemotherapy. So kind of going through that routine, you know, maybe stopping and getting breakfast and then going to the bookstore and buying a book to take with them to their treatment. Perhaps walking through the doors of the treatment facility. All of these things can kind of trigger previous experiences, and this is what we call anticipatory nausea and vomiting. Again, it's really important to know the difference specifically with this type of nausea and vomiting because it is treated much differently than the other types. Breakthrough is emesis that occurs the day of chemotherapy despite appropriate prophylaxis. And then refractory is really exactly what it sounds. It occurs during treatment cycles when antiemetic prophylaxis and or rescue therapy has failed. So pretty much you have a patient that is just really refractory to several types or lines of therapy. Okay, so this is kind of a closer look at what areas we're talking about in terms of mechanisms of nausea and vomiting. As you would expect, the chemoreceptor trigger zone, which you kind of see in the center of the center to the left of the vomiting center in this slide, is really one of the major areas that is associated with nausea and vomiting that occurs from the administration of chemotherapy. What is different and what you will notice is that the higher cortical center, as I stated before, is related to sensory input. And so this pertains to memory, fear, anticipation, etc. And so this is one of the reasons why we often treat this type of nausea and vomiting with a completely different class of medications. Another important thing is if you have a patient perhaps who is having some sort of GI-related nausea and vomiting, we actually recommend that you treat this type of nausea and vomiting with some sort of prokinetic agent like metoclopramide, etc. So really kind of knowing or thinking about what the causative agent is that is causing the nausea and vomiting is very important. And most of the time in our patients, it is going to be the chemotherapeutic agent itself. So after looking at each individual chemotherapeutic agent and kind of which we'll get to in just a minute, we also need to do a risk assessment for each patient. And so part of the risk assessment is really going through and trying to determine if they have any major risk factors that would put them at an increased risk for nausea and vomiting. So one of the things is patient's age. We know that our younger patients often have a harder time with nausea and vomiting than our older patients. Females, if you have a history of motion sickness, especially if females have had illness while they were pregnant or while they were carrying their child, then we know that this would also be a risk factor. If they've had previous chemotherapy and they had poor control during these previous cycles, that would also be a risk factor. And then finally, the emetogenicity of the chemotherapeutic regimen, which we're going to get into a little bit more next. What you will notice, and I would star this, which is a little bit different in terms of risk factors, is that a positive risk factor is actually a history of chronic alcoholism. And my primary practice site is actually at a Veterans Administration hospital, and so we see this all the time in patients who do have a history of chronic alcohol use that, you know, we can give them really or regimens that have a really high emetogenic risk, and they actually do really, really well, which is always very surprising to me. So put a little star by that. That is actually a positive risk factor. So if patients have a history of chronic alcoholism or alcohol use, then we know that their risk of emetogenicity or their risk of having a higher level of nausea and vomiting is actually lower. Okay, so then finally, as I stated before, we look at the emetogenicity of the chemotherapeutic regimen. There are actually several schemes that we're now on probably our third or fourth scheme in terms of how these agents are classified. You can see here it was originally classified as no emetogenic risk, mild, moderate, and severe. Then Hesketh and colleagues developed a much more extensive model where agents were broken down into levels 1 through 5, with 5 being the highest level of emetogenicity. He also had a couple of recommended rules where if you had 2 agents in one class, if one agent was a 5 and one was a 4, then the whole regimen was automatically a level 5. If you had 2 level 4s, and that would bump you up to a level 5. So there were a lot of very specific kind of recommendations on how to assess the emetogenicity of the chemotherapeutic regimen. Now we have a model that only has 4 levels, and you can see it's listed as minimal, low, moderate, high, and emetogenic risk, and it's kind of does still have a few principles from the Hesketh model, but it's really defined by the percentage of patients that experience or are expected to experience some sort of emesis when on the therapeutic agents. And so it's a little bit easier and a little bit more well-defined than it was before. And then what is really, really interesting is over the past 5 to 8 years or so, we have had a rapid increase of approvals of oral chemotherapeutic agents. And so now we actually have a classification system for these as well. So there's a really nice chart in your course book, and do I recommend that you memorize all of the drugs and where they're supposed to fit into the chart? No, I do not. What I would recommend, and this is kind of what I tell students and residents, is that you want to learn what's really high and you want to learn what's really low, and then just kind of know that everything else is in between. And when you have 2 agents that are in between, then that could potentially move you up to a higher category. Okay, so it's a lot easier to remember the really high therapeutic agents, like cisplatin, greater than 50 milligrams per meter squared, really, really high doses of cyclophosphamide, which we know we only use in bone marrow transplant. There's some additional agents in there as well. Then with the low therapeutic class, we have our Vs, our vincristine, vinblastine, vinorelbine. Any of our monoclonal antibodies, it's important to know that they don't cause any additional emetogenic risk when you add those on to a chemotherapy regimen. So those are just kind of some hints on how to kind of remember that for the exam. I don't expect there to be a ton of questions. It's probably very likely that you may have one question, but to make it easier for yourself in studying, that's what I would recommend in terms of how to learn the emetogenicity of these therapies. Okay, so getting back to our case, if you remember, this patient is a female. She has advanced lung cancer, so one of the primary therapies for advanced lung cancer is a cisplatin-based therapy. Cisplatin, we know, is a very, or is considered a highly emetogenic chemotherapeutic agent, so we are going to want to be extremely aggressive in terms of prophylaxis with the nausea and vomiting regimen. Then we kind of look at all of the potency of all of the other options that were given to you as part of the answers for the case. Prochlorperazine is not recommended for highly emetogenic regimens. It's more of a breakthrough refractory type agent. Lorazepam is the drug of choice for anticipatory nausea and vomiting, so this would not be appropriate in this specific case. And so therefore, aprepitant is one of our newest therapies. It's an NK1 antagonist. There's lots of additional information in the course book about it. It's very easy to administer, 0.25 milligrams IV push, and it's considered, that wasn't accurate. Aprepitant, NK1 antagonist. You can give it in a variety of different regimens, either oral or IV. I'm getting ahead of myself. You can give it 150 milligrams IV as a one-time dose, or you can give it in a 3-day oral regimen where you give 125 on day 1, 80 on day 2, and 80 on day 3. Aprepitant can assist with acute and delayed nausea and vomiting, so that's one of the reasons why it's recommended in highly emetogenic regimens and also moderate emetogenic regimens. Okay, so then typically with the aprepitant, we add dexamethasone, and we know that when we use this in combination with one of our 5-HT3 antagonists or our NK1 antagonist, it actually improves antiemetic activity by 10 to 20%. One of the things that's not kind of listed as a bullet on this slide is that our 5-HT3 antagonists are kind of considered our staples of nausea and vomiting management, especially in the cancer patient population. As far as we know, in various studies, several of the 5-HT3 antagonists have been compared to one another, and we know that these therapies are kind of considered equivalent, and so really one therapy is no better than the other, except for palonosetron, which was what I was kind of getting ahead of myself with just a few minutes ago. Palonosetron is kind of the lone ranger of the 5-HT3s in that it has a longer half-life. It is approved for acute and delayed nausea and vomiting. And again, you give it, as I stated earlier, 0.25 milligrams IV push. It is kind of becoming the preferred 5-HT3 antagonist, although it's a little bit controversial because it is very expensive. We're talking about $100 to $200 a dose. That is a lot of money, especially when thinking about how ondansetron is now generic, and we can actually give ondansetron in a variety of different administrations. So, you know, oral, the sublingual tablet, we can give it IV, etc. So kind of just something to think about. Low-dose metoclopramide was another option, has activity similar to phenothiazines. At higher doses, they block serotonin receptors, but we do know that at higher doses, they cause a lot of Parkinson's-like syndrome symptoms, and so we try to avoid these as much as possible. Metoclopramide is useful for preventing and treating delayed symptoms, so this can be an option. However, the best option, based off of what you were given in this case, is answer A. And that would be aprepitant plus ondansetron. And really here it could be any 5-HT3. We know that a lot of our facilities kind of have their preferred 5-HT3 agent, whether it be ondansetron or granisetron or maybe palonosetron, plus dexamethasone. Okay, so in this same case, which one of the following is an appropriate regimen for anticipatory nausea and vomiting? A, aprepitant plus dexamethasone. B, aprepitant plus metoclopramide. C, ondansetron plus dexamethasone. Or D, aprepitant plus ondansetron plus dexamethasone plus lorazepam. If you'll hold your cards up. Okay, very good. Okay, so as I stated before, anticipatory nausea and vomiting is triggered by sight, smell, sound, etc., and most of it is thought to be due to inadequate control of nausea and vomiting in the past. Serotonin receptors in this type of nausea and vomiting are generally not thought to be effective at all for anticipatory symptoms, so ondansetron and dexamethasone would really not be a great option in this setting alone by itself. Okay, so aprepitant plus dexamethasone is a great option for delayed nausea and vomiting. As we just stated, typically it is used in combination with the 5-HT3 antagonist. That's the way it was studied. That's the way it was approved. But we know that this therapy by itself does not really assist with any anticipatory type symptoms. And then finally, the other option was aprepitant plus metoclopramide. And again, this would not be recommended for anticipatory nausea and vomiting. As we stated before, we don't really think that serotonin at all is involved in this type of nausea and vomiting. So specifically, what do we use for the treatment of anticipatory nausea and vomiting? The benzodiazepines are the treatment class of choice, especially lorazepam. It has minimal antiemetic activity as a single agent, but it is useful in combination as it was one of your options in this case, or as an adjunct to other antiemetics. And if you actually pull there's a variety of different guidelines that we do utilize to assist us with treatment recommendations. The National Comprehensive Cancer Network Guidelines is one of those. It's updated several times throughout the year. If you pull those guidelines and look at them for every level of emetogenicity, whether it's high, moderate, etc., they will always say at the bottom plus or minus lorazepam for anticipatory nausea and vomiting. So it's expected that we should assess anticipatory nausea and vomiting really for every single patient, regardless of what risk factor they have and regardless of what level of emetogenicity of the chemotherapeutic agent they are receiving. So just kind of keep that in mind. That's really important. Anterograde amnesia helps prevent the anticipatory nausea and vomiting, and this is actually kind of a positive effect that we would want in this type of setting for these for these symptoms. It does cause help assist with relief of anxiety. We know a lot of these patients are very anxious when they come in, especially if they've had a bad experience with nausea and vomiting before. So it's very understandable that they would be very anxious about having those types of issues again. Management of akathisias caused by phenothiazines and some of these other therapies, et cetera, benzodiazepines can be used for the management of akathisias caused by some of these other therapies. So for whatever reason, if they are refractory or taking some of these for breakthrough, then the benzodiazepines can also assist with the treatment of this as well. So just another positive aspect. I'm sure you're all familiar with the adverse effects of benzos, amnesia, sedation, hypotension, perceptual disturbances. Again, we do want some sort of amnesia and sedation as part of really the main reason why we would want to use this therapy is to assist with those types of symptoms. So really, when looking at the whole patient as a whole and trying to assess what would be the best regimen in this setting for a patient who's having, who's receiving high-dose cisplatin and also having anticipatory symptoms, the best answer would be answer D, that she receive aprepitant, ondansetron, dexamethasone, and lorazepam. So very good job. Okay, so that we're now to patient case number 3. A 75-year-old man has metastatic prostate cancer. His main sites of metastatic disease are his regional lymph nodes and his bone. He has aching pain with occasional shooting pains. The latter are thought to be the result of nerve compression by enlarged lymph nodes. He has been taking oxycodone, APAP, combination product, the 5 milligrams of oxycodone, 2 tablets every 4 hours, and ibuprofen 400 milligrams every 8 hours. Notice that the combination opioid product is scheduled. Okay. His current pain rating is 8 out of 10, and he states that this pain cannot be controlled. Which one of the following choices is best to manage his pain at this time? So A, increase oxycodone APAP to 7.5 milligrams, 2 tablets every 4 hours. B, increase oxycodone APAP to 10 milligrams, 2 tablets every 4 hours. C, discontinue ibuprofen and add morphine SR every 12 hours. Or D, discontinue oxycodone APAP and add morphine every 12 hours. So if you'll raise your cards. Okay, a little bit of a mixed answer there. Okay, so one of the things that we do have to remember when we're treating pain and assessing for pain is to take into account the patient's actual report of their pain level. So the severity of pain is determined by this case that the patient has a severity level of 8 on a scale of 0 to 10, with 0 being the no pain, 10 being the worst pain that they've ever had in their life or severe. We want to select a drug and dose to match the severity of pain. And often, too, we want to think about what kind of regimen they're on, and I kind of pointed this out in the case, whether that regimen is something that is being given PRN or whether it is being scheduled. We also want to consider the limitation of combination products containing acetaminophen and or aspirin. And so this is really important, and this often kind of inhibits our ability to increase the opioid because of that acetaminophen and or aspirin component. So for persistent severe pain, agents with a long duration of action are more convenient. And so NSAIDs may also be useful for bone pain, however they do not replace opioids, so we would not want to just give NSAIDs by itself, for example. And so really the best answer is answer D, discontinue oxycodone APAP and add morphine SR every 12 hours. Now, I'll always get a couple of questions about this every year. specifically, well, why couldn't we just increase the oxycodone? And really, I think the best explanation or the best answer for that is since it's already scheduled, we are going to be limited. And if we have to continue to increase the dose, and again, we are limited by the amount of APAP that we can give, we can switch to another product as we do many times with patients. And I think that this would be appropriate to do perhaps if it was only being administered PRN. But because the patient is having a very, very high pain level, at this point it probably would be the best recommendation to just switch to a longer acting opioid instead of increasing the or changing to a higher strength combination product. The other important thing to remember is to, in a lot of our solid tumor patients that have bone metastases, it is helpful to keep some sort of NSAID on board to assist with that bone pain. And so we would not want to discontinue the ibuprofen in this setting. Patient case number 4. Which one of the following might be an additional change in this patient's pain regimen? So if you recall, this patient had some, or is thought to have some, nerve involvement or nerve damage, so the tumor is actually impeding or pressing on a nerve. So the options are A, naproxen, B, single agent APAP or acetaminophen, C, gabapentin, or D, baclofen. All right. So adjunct analgesics are drugs whose primary indication is other than the pain relief itself. There are a variety of different adjunct analgesics that can be used. They're often added to opioid regimens for specific pain syndromes. Keep in mind, as I stated before, NSAIDs are typically for bone pain, and pain from bone metastases is very common, especially in a prostate cancer patient where the primary metastasis site is the bones. Antidepressants and anticonvulsants are useful in neuropathic pain. Opioids are typically less effective, and there's a lot of data that tells us that these therapies are not very good with the neuropathic-like pain. Neuropathic pain is very common in cancer patients, and we don't always know the source of the neuropathic pain, but most of the time it can be identified with the tumor actually itself infiltrating the nerves or a result of nerve compression by the tumor, as I stated before. Remember the key kind of symptoms that you should look for on the case for the exam. So any type of neuropathic pain is often described as sharp, burning, shooting, numbness, tingling, etc. So anytime you see those symptoms and you're given an option for either an anticonvulsant or a therapy like gabapentin, then most likely gabapentin is probably going to be your best option. So the answer here, the most appropriate answer for this case would be answer C, gabapentin. Okay, patient case number 5. A 50-year-old woman is receiving adjuvant chemotherapy for stage 2 breast cancer. She received her 3rd cycle of doxorubicin and cyclophosphamide, what we commonly call AC, 10 days ago. Her CBC today includes a white blood cell count of 600. Her neutrophils are 60%. She has bands of 10%, monocytes 12%, basophils 8%, and eosinophils 10%. Which one of the following best represents this patient's ANC? So A, 600, B, 360, C, 240, or D, 420. So if you'll raise your cards. All right, so the first thing to understand is that the absolute neutrophil count is the number of neutrophils and bands, and this is a very important measure that we utilize when administering chemotherapy. We often say, we look at that number to kind of help us determine is it safe to actually give our patient chemotherapy, or are they kind of below the threshold where we know that they are at an increased risk for infection. You can see here it is considered neutropenic, but we do know the risk of infection actually increases as the ANC drops below 1500, and the longer that it actually stays below 1500 as well, we actually know that the patient is at a higher risk for infection as well. So this is a very simple calculation. all you do is you add the segs and the bands, and then you multiply that by the white blood cell count. So you can see 0.6, I just converted this from percentage, 0.6 plus 0.1 times 600, and that would give you 420. So the answer is actual D, 420. And I put a star beside that equation. You never know when you'll get asked just a simple question about, how to calculate ANC. So that is an equation you want to make sure that you know and you remember either for the exam or for the post-test for this course. So based on this ANC in this patient case, which one of the following statements is most correct? A, the patient should be initiated on a colony-stimulating factor. B, the patient should begin prophylactic treatment with either a quinolone antibiotic or Bactrim. C, the patient who is neutropenic should be monitored closely for signs and symptoms of infection. Or D, decrease the doses of doxorubicin and cyclophosphamide with the next cycle of treatment. Okay, so colony-stimulating factors are actually one of my favorite things to talk about, and I could talk probably for about an hour pertaining to these agents by itself. These are agents really that have made huge breakthroughs in the area of cancer treatment and have allowed us to kind of push the envelope with some of our therapies in administering chemotherapy. These are generally used to prevent neutropenia, and what I often tell a lot of our students, residents, patients, when talking to physicians, that we kind of feel like as practitioners who practice oncology in the outpatient setting, it's our job to try to prevent our patients from getting neutropenic and getting admitted to the hospital. So we want to utilize these therapies when appropriate, and we'll talk about that, but we want to use these if we can, to try to prevent a patient from, one, getting admitted to the hospital, getting an infection, and then also, two, depending on what type of cancer they have and what stage of cancer they have, we want to try to keep their therapy on schedule as much as possible. This is kind of an important concept. I don't think that this will really be stressed a lot on the exam, but just so that you know when you're going through and studying for the exam, one of the things that we talk about when use of colony-stimulating factor is the curative setting versus the non-curative setting. And one easy way to remember that is the non-curative setting would be where you actually see a patient who has stage 4 metastatic cancer. So 99% of the time when you're treating a patient who has stage 4 metastatic cancer, you're really treating for palliative type reasons. You're treating to assist with progression-free survival and not necessarily perhaps going to be able to give them a very long sustained overall survival. Okay? In comparison to the curative setting, which most of us and most of these therapies were actually studied in the setting of early stage breast cancer and lymphoma. So most of the time when we're talking about curative setting, or if you're reading some of these studies, you'll see that a lot of these agents, filgrastim, pegfilgrastim, sargramostim, these agents were approved by its use or prevention of neutropenia in patients with breast cancer and lymphoma. And one of the things that they found in those studies was, when you utilize these, you kept the patient on time with their regimen, and that was thought to have an impact or an effect on their overall survival. So that's what we mean by curative and non-curative setting. So I'll come back to that, kind of keep that in mind. Treatment of established febrile neutropenia should be considered when the patient is at risk for complications from infection. And one of the things that we have to think about is the actual nadir. So if you remember back from pharmacy school, nadir is the lowest point at which a white blood cell count drops. And each chemotherapy agent and regimens will have a specific nadir for that treatment type. In general, most regimens nadir somewhere around day 7 or around day 10. And that's why a lot of our chemotherapeutic agents or regimens are given every 2 to every 3 weeks, because we expect their immune system to bottom out somewhere around the 7 to 10 day. They have a little bit of recovery time, and then they are administered another cycle of chemotherapy. If subsequent chemotherapy is delayed due to low ANC, then a colony-stimulating factor should be given after the next cycle. And this is, again, in the curative setting. So for an example, if you have a breast cancer patient, if you have a lymphoma patient, if you have early-stage breast cancer, if you have an early-stage lung cancer patient, a non-metastatic stage 4 type patient, if that patient develops febrile neutropenia in the first, second cycle or so, and they still have several cycles remaining in their treatment regimen, then it would be appropriate to implement a colony-stimulating factor after that episode of febrile neutropenia. And that's what we call secondary prophylaxis. Okay. The other option, and this is often kind of controversial, but there's a lot of data to support this too, it's controversial in that it depends on who you ask in terms of kind of what side they stand on. For example, if you have a patient that is in the non-curative setting, you could just recommend, instead of getting a colony-stimulating factor after they develop an episode of febrile neutropenia, you could just recommend a dose reduction. Because remember, the non-curative setting, it's very likely we're not going to get a very sustained overall survival benefit. It's going to be more of palliative therapy, treatment of symptoms, looking at progression-free survival, so it's not going away, but perhaps the tumor's not getting any bigger, etc. The reason why that's controversial is because some practitioners would say that you're still keeping them out of, by giving colony-stimulating factor, you're still keeping them out of the hospital, you're still keeping their chemotherapy regimen on track, and so it's thought that you're still kind of improving the quality of life of that patient. However, from a pharmacoeconomic standpoint, we know that it's kind of recommended that colony-stimulating factor not be administered in the non-curative setting, that we could actually just give a dose reduction instead of spending, $1,000 to $2,000 for a treatment course with colony-stimulating factors. The final option for this case was prophylactic antibiotics are not recommended in this setting because this patient is a solid tumor patient and because they are afebrile. And that's another important fact to kind of remember as well. If you have a patient that is afebrile, colony-stimulating factor is kind of not recommended. So you would just kind of watchful waiting, monitor for signs and symptoms of infection, unless they're actually presenting with signs and symptoms. There's not a lot of data that shows that if a patient is afebrile, and this comes straight from the guidelines, if they're afebrile, that you should actually give colony-stimulating factor for the treatment of that neutropenia. Now, once they become febrile, then yes, it can be recommended that they be used as an adjunct, especially if they're considered high risk. If they have pneumonia, if they have hypotension, if they have some sort of fungal infection, then these therapies would be kind of recommended in that setting. But getting back to the prophylactic antibiotics, we really only use prophylactic antibiotics, for example, quinolones, Bactrim, etc., in patients that we know are at a very, very high risk of febrile neutropenia. Those are our kind of more fragile patients, our acute leukemia patients, maybe even lymphoma patients, and our bone marrow transplant patients. So the best answer for this case would be answer C, because the patient is afebrile. The patient who is neutropenic should be monitored closely for signs and symptoms of infection. Okay, patient case number 7. A 45-year-old woman is beginning her third cycle of chemotherapy for the adjuvant treatment of breast cancer. Adjuvant treatment means pretty much early stage breast cancer. It kind of has a couple of different definitions, and as someone who works in oncology, we use it in a variety of different ways. It can either mean early stage breast cancer, or adjuvant can be in addition to the primary treatment, which is typically surgery. So the primary treatment for most solid tumors is considered surgery, and then anything you do additional to that is called adjuvant treatment. Okay, so that's kind of an important definition to remember. At diagnosis, her hemoglobin was 10 grams per deciliter. However, today her hemoglobin is less than 10 grams per deciliter. The patient is experiencing considerable fatigue that is interfering with her activities of daily living. Which one of the following statements is true? A, treatment with epoetin should be considered. B, treatment with darbepoetin should be considered when the hemoglobin falls to less than 9 grams per deciliter. C, patient is being treated in the curative setting and therefore is not eligible to receive an ESA. Or D, the patient should not receive RBC transfusions because she is symptomatic. Okay, so if you'll raise your cards. All right. So fatigue in cancer patients has multiple causes. It's often there's been actually a couple of studies that have shown that this is a symptom that, as practitioners, again, we often don't do a very good job of assessing. And there was actually a survey that was published several years ago that showed cancer patients really think of fatigue as being more of an issue than nausea and vomiting, than pain. And so because there are not a ton of things that we can do for fatigue, and it can often be multifactorial in terms of the causative reason why they're having fatigue, it makes it a little bit more difficult to treat and to manage. But we do know that one of the major reasons for cancer patients becoming fatigued is they could have developed anemia. As we know, a lot of our therapeutic agents do cause a variety of hematologic type toxicities, and anemia being one of those. Fatigue represents more than just feeling tired and can actually compromise quality of life. There have been several studies, again, that have been published that have shown that fatigue does have a direct effect on quality of life. Attempts to increase hemoglobin with erythropoiesis-stimulating agents have been associated with decreased survival in some cancer patients. This is kind of a hot topic still, I guess you could say, but was really more of a hot topic 5 to 6 years ago. When, just to give you a brief background information, there was a study that was conducted. It was called the BEST study. It was published again probably right at 7 years ago now, that actually looked at early stage breast cancer patients, as I was stating before, who were being treated in a curative setting, and they were randomized to receive either standardized treatment or standard treatment, which was an anthracycline-based regimen, in addition to erythropoiesis-stimulating agents for prevention of anemia. What they found in this study was that they actually had to stop the study early because the patients who were in the arm that were being treated with the erythropoietic stimulating agents actually ended up having a worse survival outcome. And so this was kind of a big red flag. Now, one of the critiques of this study was that in the study they were actually aiming for hemoglobins of 14. And so, as most of you know who treat patients, we typically do not continue to give patients therapies, especially erythropoietic stimulating agents, to a goal of hemoglobin of 14. Usually around 12, and per the package insert, we're going to stop. We're going to stop these therapies. We're going to reassess, wait till the hemoglobin drops back, and then determine when would be an appropriate point to reinitiate these therapies. So this kind of started a lot of controversial discussions, mandates. The FDA met several times. The subcommittee, the oncology subcommittee, ODAC, met several times over the last 7 years. And so we now have a new process and a new recommendation. It is erythropoietic stimulating agents, as in your course book, are under the REMS program. And so it is recommended now that these therapies only be given in the non-curative setting. So that's really important, the non-curative setting. So the use of ESA should be limited to patients whose hemoglobin is actually less than 10. And this is kind of different because initially when they were approved, we were treating patients and initiating these therapies much earlier. And there was actually data that showed that these therapies were much more effective when they were implemented in patients who had a hemoglobin of 10 to 12. So very, very different treatment recommendations than what we were doing, say, 6, 7, 8 years ago. The other big thing to keep kind of note of, or to put a star beside, is that these have to be patients, in order to utilize these therapies in the setting of oncology, other than in the setting of myelodysplastic syndrome. These patients have to be on active chemotherapy. So before, patients were receiving these therapies for cancer-associated anemia. So they have a cancer, they get therapy, they stop therapy, and then, 6 months to a year later, they're still experiencing some sort of anemia, and that was termed as cancer-related anemia. So the recommendation now is that we shouldn't be giving these therapies anymore for that indication, that it really should only be in patients either for chemotherapy-induced anemia, they're receiving active chemotherapy, or in the setting of myelodysplastic syndrome, which I have no doubt in my mind you're probably not going to get asked a question like that on the exam. So you don't have to worry about the MDS indication, but that is for your information. So again, we only want to use these in patients with non-curable cancer. So transfusions are kind of now ramping back up. You know, before it was we were transfusing a lot of patients. Then we kind of stopped transfusing a lot of patients. We started using a lot of ESAs. Now we've kind of stopped using a lot of ESAs, and now we're using a lot of transfusions. The unfortunate downside of that is we have to wait until a patient's hemoglobin drops fairly low before we can initiate those transfusions, and often at that point those patients are symptomatic. So kind of looking at this case, because the patient is being treated for breast cancer in the adjuvant setting, ESAs would not be appropriate. So again, she was an early stage breast cancer patient. If this was a patient with advanced breast cancer, key term here, advanced or stage 4 metastatic breast cancer or lung cancer, then these agents would be an option. And honestly, I don't even really think they're probably going to be that tricky on the exam. But I kind of would know that, you know, as we stated before, curative versus non-curative intent, just to assist you with kind of answering some of these cases. So the best answer for this case would be answer C. Patient is being treated in the curative setting and is therefore not eligible to receive an ESA. Now, we know that her hemoglobin is less than 10. We were not given a specific number, but we know that, you know, once it drops below 9, physicians, practitioners are much more likely to recommend a blood transfusion, usually on the lower side of, you know, 8.5 below before we'll actually transfuse. But, you know, if a patient is symptomatic, then again, that's normally one of the key kind of things that we'll think about when trying to determine how we're going to treat this patient's anemia and or fatigue. Okay, so patient case number 8. A 38-year-old woman has a history of Hodgkin's lymphoma. 2 years ago, she completed 6 cycles of ABVD chemotherapy. ABVD is doxorubicin, bleomycin, vinblastine, and dacarbazine. Each cycle included doxorubicin 50 milligrams per meter squared. Recently, she was given a diagnosis of stage 4 breast cancer. She will be initiated on doxorubicin 50 milligrams per meter squared and cyclophosphamide 500 milligrams per meter squared for 4 cycles. Which one of the following statements is most applicable? A, the patient has not reached the appropriate cumulative dose of doxorubicin to consider dexrazoxane. B, the patient has reached the appropriate cumulative dose of doxorubicin to consider dexrazoxane. C, the patient should not receive any more doxorubicin because she is at an increased risk of cardiotoxicity. And then D, the patient should not receive dexrazoxane because of the possibility of increased myelosuppression. So if you'll raise your cards. You guys are getting tired, aren't you? Okay, so one of the first things we have to do anytime you're looking at doxorubicin and someone's asking you about cardiotoxicity and how to assess for potential cardiotoxicity, you want to look and kind of try to determine how much doxorubicin the patient has actually received up to that point. Okay, so when we go back to this case, we know that she got 50 milligrams per meter squared of doxorubicin. This is a standard dose, especially in the setting of lymphoma and or breast cancer. And we also know that she got 6 cycles. So we just multiply 50 milligrams times 6, and that gives us 300 milligrams per meter squared. And that kind of tells us how much doxorubicin she's been exposed to per meter squared. Okay? What we also know is that the maximum lifetime cumulative dose that anyone should receive of doxorubicin is 550 milligrams per meter squared. So we still have some room and some space to go. Okay, so that's probably the first thing that you need to do when looking at this case is to determine how much doxorubicin they've received. We also have to consider the goal of therapy. It's palliative for metastatic disease, and one of the reasons for that is an early study actually suggested a decreased response rate to doxorubicin when a cardioprotectant like dexrazoxane is actually used to prevent cardiotoxicity, and so that's one of the reasons why dexrazoxane is only approved in the metastatic setting. And then dexrazoxane may actually add to the hematologic toxicity of the chemotherapy. And this is something we have to weigh. And this is kind of looking at the risk versus the benefit of treating this patient with an anthracycline or not. And or if the physician is adamant or determined that they want to give an anthracycline-based regimen in this setting, then we have to kind of do our job to try to protect the remaining heart function that this patient has as much as possible. So clearly protecting this patient's heart function outweighs the risk of the hematologic toxicity. So we may just have to do some, additional monitoring. So as I stated before, dexrazoxane may be considered for patients with metastatic breast cancer who have received a cumulative dose of doxorubicin of greater than or equal to 300 milligrams per meter squared, which this patient has received that actual exact amount, and who may benefit from further drug therapy with an anthracycline. Again, this patient has received a cumulative doxorubicin dose sufficient to receive dexrazoxane, and again, when weighing the risk versus the benefit, the best answer would be answer B, that the patient has received the appropriate cumulative dose of doxorubicin to consider giving dexrazoxane. Patient case number 9. Which one of the following is the correct sequence for administering Mesna and ifosfamide? A, Mesna before ifosfamide and then at 4 and 8 hours after ifos. B, ifos before Mesna and then at 4 and 8 hours after Mesna. C, Mesna and ifos beginning and ending at the same time. And D, Mesna on day 1 and ifos on days 2 through 5. So if you can raise your cards, what do you think? All right, I'm seeing a lot of blue. Okay, so one of the things from this section in the course book for supportive care is chemoprotectants. And so Mesna is kind of a very popular chemoprotectant that you need to remember for the exam. What does it do? It actually binds to a metabolite from two of or several of our alkylating agents such as cyclophosphamide or ifosfamide. So there's an active metabolite called acrolein. Acrolein actually binds to the bladder and causes bladder bleeding or hemorrhagic cystitis. So one of the ways that we can prevent this is by giving Mesna. Mesna itself actually binds the acrolein, therefore the acrolein can't bind to the bladder, and then therefore you don't have the hemorrhagic cystitis or the bladder bleeding. Mesna is always used with ifos because typically ifos is used in very high doses and there is a higher risk of having hemorrhagic cystitis with ifos. And it may be used with cyclophosphamide if we're using it at very, very high doses. Now, typically in the solid tumor patient population, we're going to use a dose of cyclophosphamide somewhere around 500 milligrams per meter squared to 750. So in this case, it's very likely that Mesna would not be needed. But at higher doses, 1250, 1500 or so, that we see more likely in our bone marrow transplant patient population, then Mesna would be a consideration in that kind of setting. So when bolus doses of Mesna and ifos are used, Mesna should be given before ifos, then 4 hours after, and then 8 hours after ifos. So there were a couple of different options. One was to give it just once, and then you continue to give the ifos on days 2 through 4 or 2 through 5. That would not be the option. You always want to give ifos every time you give ifosfamide. And so really the best recommendation, you want it to be on board before they actually receive the therapy. So you want to give it before ifos, and then the way that it was studied, it was given 4 hours after, and then 8 hours after the therapy as well, to attempt to prevent hemorrhagic cystitis. Okay, and then the final case, patient case number 10, a 40-year-old man is about to begin R-CHOP chemotherapy for Hodgkin's lymphoma, non-Hodgkin's lymphoma. The patient asks how long the treatment will take and whether he can be treated as an outpatient. Which one of the following is the best answer? And so just to keep in mind, R-CHOP, what is in R-CHOP? R stands for the Rituxan. C stands for cyclophosphamide. H is kind of funny. It's actually hydroxydoxorubicin, otherwise known to us as doxorubicin. O is the brand name for vincristine, Oncovin, which is vincristine. And then P is prednisone, and prednisone is the only part of R-CHOP that's actually given by mouth. So we give prednisone by mouth. So which one of the following is the best answer? A, administration of this regimen is expected to be complete in 1 hour, but because the regimen is highly emetogenic, it is usually given to patients while in the hospital. B, administration of this regimen may take as long as 6 hours because the rituximab infusion rate is slowly increased, but the regimen is usually given to outpatients. C, administration of this regimen may take as long as 6 hours because the vesicants doxorubicin and vincristine should be infused over several long hours, but the regimen is usually given to outpatients. Or D, administration of this regimen is expected to be complete in an hour, but because of the risk of tumor lysis syndrome, it is usually given to patients in the hospital. So final question. All right, I'm seeing a lot of red. So in the CHOP-R or R-CHOP, you'll hear it pronounced several different ways, regimen, all of these therapies other than the prednisone, as I stated before, are given as either bolus injections or bolus infusions minus the Rituxan. So the Rituxan or rituximab is a monoclonal antibody. If you remember back from biochemistry, one of the ways to kind of determine side effects expected from a monoclonal antibody is to look at the very last part of the word. So rituximab or IMAB. The IMAB stands for chimeric, or it means that it's a chimeric monoclonal antibody. So that means it's half mouse, half human. So one of the things that we always know is associated with any type of chimeric monoclonal antibody when administered is infusion type reactions. Okay? So because of this, it is often given over a very long time period. You have to start it at a very slow rate and then slowly increase the rate as you go. Both doxorubicin and vincristine are vesicants, and it is generally preferred to give vesicants as bolus injections. Another kind of key point is that vincristine is often given as a short infusion now to avoid inadvertent intrathecal administration, and this is kind of an FDA-mandated regulation for the past 7 or 8 years. So regardless of how many kind of manufacturer implementations, wrappings, stickers, things like that, that were supposed to have been placed on a vincristine syringe, it was still accidentally given intrathecally, and so now the recommendation is that even though it is a vesicant risk and we do worry about extravasation in these patients, we do have to give it as a short infusion in a mini bag instead of as a push in a syringe. So as I stated before, rituximab, remember it is a chimeric monoclonal antibody, and so the rate of administration is usually very slow, and then you slowly work your way up. The risk of an infusion reaction is typically the highest at the first dose or the first administration, although it is known patients can have reactions after that first dose. Highly emetogenic chemotherapy is commonly given in the outpatient setting with appropriate antiemetic prophylaxis. And really the point of this statement is just because a patient is receiving a chemotherapeutic regimen that does have a high risk of causing nausea and vomiting doesn't necessarily mean that they have to be treated in the inpatient setting. So we treat a lot of our standard tumor types in the outpatient setting now. Another important thing to remember, as we stated earlier, is that just by adding a monoclonal antibody to a regimen doesn't add any additional emetogenic risk, as it wouldn't in this setting. Tumor lysis syndrome occurs subsequent to cell death in tumors that are rapidly growing and are highly chemosensitive. However, this again would not be a reason why we would need to admit somebody into the hospital for prevention of tumor lysis. We can do this if we are, say treating lymphoma, as in this case, in the outpatient setting, simply by giving the patient lots of fluids and giving them some allopurinol to take it home. Large cell lymphoma is considered intermediate in terms of risk of developing tumor lysis syndrome, but still, as I stated before, can be commonly treated in the outpatient setting. So the best answer for this case would be answer B. Administration of this regimen may take as long as 6 hours because the rituximab infusion rate is slowly increased, but this regimen is usually given to our outpatients. All right, and we are done with 2 minutes left.